Thanks for the warm welcome. It's a pleasure to be here with you all today. I'll start off and then we'll be passing back and forth a little bit during the presentation just to keep you interested. I was thinking back, so yeah, collaboration is important in this, and Vikas and I, maybe you don't all know that we actually trained in the same year in cardiology in the program when Lisa Welikovich was the program director, along with Angie Keeley, and we've kind of worked together side by side ever since, and it's been really fun. So it's nice to do this presentation again with Vikas today. Go to the next slide. We have a couple of disclosures. Here are mine, none really directly relevant to this presentation. And here are Vikas's. So we wanted to cover three main topics today. We know that left atrial appendage occlusion is not a new procedure, but I think it's relevant to go through some of the background and how we're thinking about it now in Calgary and selecting patients. And then we're going to talk about some of the ongoing controversies related to this therapy and some of the unknowns that are yet to be resolved. And then some recent experience we've had with combining appendage occlusion and catheter ablation in the same procedure. It's kind of an interesting sidebar. So in terms of background, really brief anatomy lessons. So the left atrial appendage, as you all know, is located on the anterior surface of the left atrium. It has a couple of unique features, so very different than it has a different embryological origin than the posterior left atrium, where we're often working for ablations. Really trabeculated muscle, much more like the right atrium. And it does have important cardiac functions, so it acts as a reservoir in diastole. It's a big component of the atrial kick in patients who are in sinus rhythm, and also is a source of ANP and thirst regulation. So when people describe that they have to pee a lot right after they go into atrial fibrillation, it's the appendage's fault. It's making ANP and making them go pee. The other thing about the appendage is that because of its shape and location and trabeculated muscular nature, it is a nidus for thrombus formation, unfortunately, as we know in patients with atrial fibrillation. So the whole idea of treating the appendage separately came about after this old study now, a 25-year-old study, looking at the sources or the sites of thrombus detected in people who had atrial fibrillation. And they found that of those who had a thrombus detected either at TEE or autopsy or at surgery, over 90% were in the appendage. And this is in patients with non-valvular atrial fibrillation, different situation in the rheumatic patient. So that kind of led for calls very early on to say that we should maybe treat this locally. And it's actually remained controversial whether that's really a good idea or not. I think to date, the best evidence that the appendage is a source of an important cause of stroke comes from the LAAO studies, and in particular the LAAO 3 study that was published just last year, a Canadian-led study, as you all know, showing that in patients going for cardiac surgery, most of whom in both groups were anticoagulated, removing or occluding the appendage at the time of surgery did lead to a substantially reduced risk of stroke in long-term follow-up. So I think very good evidence that the appendage does have a role to play in the genesis of stroke in patients with atrial fibrillation. Next slide. So everyone on this meeting will be familiar with this figure. This is from the Canadian Guidelines for Stroke Prevention. And I'm only putting it up just to recognize the primacy of oral anticoagulant therapy in patients who are at elevated risk for stroke, really based on the CHAD65 algorithm. We recommend oral anticoagulants, and in this guideline, DOACs or NOACs are the preferred recommended therapy for most patients. For the first time actually in the guidelines in 2020, there was good discussion and a recommendation around left atrial appendage occlusion. And you can see that it is given a recommendation for people who have absolute contraindications to oral anticoagulant and who are at relatively high risk for stroke. And that's a weak recommendation with low quality evidence. And again, in the text below that, you can see that there is ongoing recognition that this is something that has to be individualized, and that in all cases, a good consideration of whether oral anticoagulant therapy is really contraindicated needs to be had before deciding to proceed with that procedure. And I think these are reasonable guidelines. Slide. So what about oral anticoagulant therapy? Are we doing well enough at getting our patients treated? I'm going to show you a couple studies that I was involved with. This one is using Alberta data and covers the time period during which direct oral anticoagulants were introduced into the market, and to see whether, as we expected, that this would lead to a improvement in the rate of use of oral anticoagulants. And so this study looked at basically all comers with new atrial fibrillation over that time period in Alberta, and we found that the overall rate of oral anticoagulant didn't change a lot. It improved by 3 or 4% during that time. And we did see a steady and significant switch from warfarin to DOAC as expected. We also didn't see much in the way of a reduction in the rate of stroke during that time. So there's still, what I'm trying to say here is there's still room for improvement. This on the right panel here is a more elegant study. It was just published by the group in British Columbia looking at their population health data, showing that in people who start an oral anticoagulant for atrial fibrillation, there are these groups of people you can identify using sort of sophisticated statistical modeling, and how they manage it over time. So luckily, about 3/4 of patients do tend to stay on it, although they still have imperfect adherence. So that top line is around 80% adherence, and about 3/4 of patients are on that. And then there's the rest of the patients have these different trajectories where they can either steadily drop off, they can drop off and then restart again, or they can just never really adhere to the therapy. And these are the groups that we often worry about in that they're not getting appropriate stroke prevention. Next slide. We've also looked at patients, from the patient level, what they care about probably is whether there's a stroke or not so much how much medicine they have to take. And we published this a little while ago, just using CHI data all over Canada, again, covering that period when DOACs were introduced, and found a very slight, though statistically significant, reduction in the overall risk for stroke in patients who'd been hospitalized with atrial fibrillation, and really no change in the risk for bleeding during that time, at least major bleeding that required hospitalization. So again, the DOACs, while they've been important improvements, haven't really dramatically moved the needle on the outcomes that we care about so far. We need to update this data to more recent data to make sure that's still the case. So yeah, next slide. So most of you will be familiar with the data around the left atrial appendage occlusion devices. I'm going to focus on the Watchman device from Boston Scientific, which is the one that we mainly use here. So the original studies were done in the early 2000s, the PROTECT AF study and the PREVAIL being the two randomized studies, both non-inferiority trials against warfarin in patients who were eligible to receive either therapy, so not the anticoagulant contraindicated patients, but those who are eligible to receive either therapy. And when this slide was made, there were a couple of registry studies as well that supported it. But still, a total of 2,000 patients, still very small numbers compared with what we know about the DOACs in particular, or warfarin prior to that. So next slide. This slide just summarizes the types of patients who got into those studies, really emphasizing that, the majority of these people had quite elevated risk for stroke in the setting of atrial fibrillation. 3 or 4 is the most common CHADS VASC score rather. And they also had elevated risk for bleeding, as you can see on the next slide. So we're using the HAS-BLED classification. Almost no patients had no bleeding risk, and then many had very significantly elevated bleeding risk. And that's kind of been our experience. This isn't something that we would recommend in all patients for sure. Next slide. So from those 2 early randomized trials, there was an individual patient meta-analysis, or they pooled the data together, thinking that they were similar enough, and really calculated the risks of the different outcomes that we would care about. So if you look at all strokes, there's really apparently no difference compared with therapeutic warfarin. Looking at ischemic stroke, however, we do see that warfarin is substantially better, whereas hemorrhagic stroke is much better in the Watchman group in these trials. And then there was a signal towards reduced cardiovascular unexplained death in the Watchman arms of those trials, although I think there's some doubt about whether that's really a real signal. Next slide. The newer study that's come out recently and has received some attention is the PROG-17 study done in Europe. This was an investigator-initiated study, and so patients could receive any approved device. Mostly it was Watchman, but there were some other devices in there as well. And they had to have elevated risk for stroke and bleeding, or else have had an event while on oral anticoagulant or had significant clinical bleeding. And they were randomized to direct-acting oral anticoagulant therapy or left atrial appendage occlusion. And the DOAC could be any approved DOAC as well. And they had a primary endpoint that was a little confusing and hard to understand, sort of a mixed bag of all bad things that could happen to a person who was undergoing these procedures, including stroke or systemic embolism, major bleeding, cardiovascular death, or procedure-related complications. In that study, which had only about 400 patients, 10% could not have an appendage occlusion device successfully implanted, and so they crossed over to DOAC, which is a significant issue in non-inferiority studies. So next slide. The overall result for the primary endpoint was that they deemed the occlusion device to be non-inferior when you put all those endpoints together. Although you can see there was some differences in the different endpoints, the study was far too small to really adjudicate superiority of one approach over the other. And it's important to recognize there was a 5% risk of major complications, including a 1% risk of procedure-related death in the appendage occlusion group in this study. So next slide. This leaves us right now in a situation where it's still hard to select patients who would be good for this procedure. The randomized data that we have comes from patients who are eligible for an oral anticoagulant as an alternative, whereas in our Canadian practice, and we know this is true across our country, that's not how we're using this device. All places in Canada, and especially and including us, only really apply this treatment for those who have contraindications to oral anticoagulant therapy that are relatively strong. And those include, sorry, I'll just go through. We want to treat people with non-valvular AF. We don't see that many patients with rheumatic heart disease anymore, but those patients have a much higher likelihood of having non-appendage related thrombus. They have to have reasonably elevated CHAD scores and have a contraindication. I would say that of the patients we've treated in Calgary, almost all of them have had intracranial bleeding and pretty strong contraindications to resuming anticoagulant. And they need to be suitable for a procedure, both anatomically as well as this bleeding risk cannot be so elevated that they can't take anticoagulant for a period of time, typically, several weeks to a few months. One slide. This is a very recent study that I thought I would highlight. It's a multi-center trial done in the UK where they took people who had intracerebral hemorrhage and AFib and elevated stroke risk and actually randomized them to resuming an oral anticoagulant after a period of recovery or not taking it. And I think this study really emphasizes that these patients, to put it sort of casually, are really between a rock and a hard place. So you can see on the left-hand side that if they started anticoagulant again versus avoided it, they had about a doubling in their risk for major bleeding, and that almost all of those events were fatal. So seven deaths from intracerebral hemorrhage in this study of 200 patients. On the other hand, in the next grouping, you see that those patients remained at relatively high risk of ischemic stroke if they did not take an oral anticoagulant, and that they did continue to have a significantly elevated risk for dying. So these are tough patients to treat. They have risks in both directions. And I think this study does highlight that at least in the ICH patients, the Watchman might be an intermediate therapy that we ought to consider. So I'm going to pass over to Vikas now to continue, and I'll mute my mic.
Oh, thanks, Steve. That was a nice lead up to this. And there are controversies with left atrial appendage occlusion. In fact, I would say in EP is probably one of the most controversial areas where there's lots of people, like media figures like John Mandrola, who are very vocal about this. But I think a lot of those are very, reasonable concerns, and we should probably discuss them as well. I mean, first of all, I think it's very clear that anticoagulation works very well. Even when we only had warfarin, compared to placebo, it's a 64% relative risk reduction, which is very impressive and much more impressive than most of the therapies we have in medicine. And when you compare it to aspirin or clopidogrel, again, it's impressive. We don't really do randomized studies of DOACs versus placebo or aspirin because the standard, of course, would be warfarin now. But when we have done them, when you look at either Avaros or with elder care with a very low dose of edoxaban, they're still suggesting that those actually work pretty well. And in fact, the bleed risk in Avaros was similar to aspirin with the apixaban as well, important to notice. So, what are the issues with the appendage closure studies? Well, let's take a step back. So, percutaneous left atrial appendage closure has been kind of now around for about 20 years. In 2001, there were animal studies using the Plato device, which is actually a nice abbreviation. It stood for percutaneous left atrial appendage transcatheter occlusion. And that's the device in the right upper corner of the slide. It actually then went to some human studies as well. Then down the line about around 2009, 2010, it just kind of dropped off. And I think there were sort of business reasons why the manufacturer didn't want to continue with that. Since then, there's been a few other devices developed. The most well-known is, of course, the Watchman, with now over 150,000 implants worldwide. The latest version is the Watchman FLX, which we've now had for available for a little while, which has some improvements in design compared to the original Watchman. But there are quite a few devices that have been around, and some are actually being developed and studied right now. The Amplatzer plug has been used quite often before, and which is now the more improved version is the Amulet from Abbott. There's also other devices being studied. They're all kind of the same idea. It's through an endocardial transeptal approach to the left atrium. There's some sort of a nitinol frame with a polyester covering, and expands inside the left atrial appendage. The only one device that's a little bit different is the Lariat device, and I'll talk about that just a little bit later on. Steve already mentioned the main randomized studies, which are PROTECT AF, PREVAIL, and Prague. And the PROTECT AF study was the first one that was done, and it actually wasn't enough data for the FDA to be convinced of using the Watchman. They actually required a second study, which was the PREVAIL study. And in the meanwhile, there was also a continued access protocol registry called CAP that had data. So when the data from all three were combined is when actually the Watchman got approved in May of 2015, and Health Canada approved it in January of 2016. And Steve mentioned the Prague study, which actually didn't specifically look at Watchman. It could be Watchman or Amulet device versus DOAC. And on the bottom right corner, you can see that, again, similar findings to the other studies with no reduction in stroke or TIA, but the combined and sort of relevant bleeding endpoints were better with the device. And the criticism of these studies are, compared to now our DOAC studies, which are anywhere like from 14 to 20,000 patients, these studies typically have about 400 to 700 patients. They're pretty small. There have been some concern, especially in PREVAIL and PROTECT AF, about the INR and TTR and how well was it regulated. And again, there's no reduction in ischemic stroke seen in the device arm. And you could argue maybe that would be hard to beat an anticoagulant because they're actually quite good. And there is less hemorrhagic strokes as we'd expect because the patients usually come off anticoagulation in the long run. The Lariat device I'll mention a little bit just because it's a little bit of a different device. It's commonly used in some centers in Europe and the US. It's not used at all or very minimally in Canada. It's a combined endocardial and epicardial approach. So the endocardial part is very similar to the other devices. We go from the femoral vein, do a transeptal to the left atrium. And then the epicardial approach is like what we do for an epicardial ablation. So we do a subxiphoid percutaneous epicardial approach. So over here's a nice model of the bottom. So you can see that this is the endocardial catheter coming in into the left atrial appendage. At the tip is a magnet. So once you get your epicardial access, you come in on the epicardial surface, and there's a magnet that attaches to the other one so you can align your equipment. Then this piece is also connected to you like a lasso type device. You inflate a balloon to keep the appendage stable, and then you put your lasso around the appendage, and basically you're tying it off. And the idea is, of course, that when there's nothing left endocardially, so you don't need anticoagulation after. And because eventually you've tied off the appendage and it basically disintegrates and goes away, you're actually getting rid of the electrical foci for AFib that in some people can have major players in the appendage. So you may help control AFib better as well. Again, unfortunately, there's no randomized trial. One of the studies that was done actually had a pretty high tamponade rate of serious tamponade requiring cardiac surgery, which was a concern. And one of the biggest concerns is this is one of these sneaky devices that got in where it had a approval for soft tissue closure in surgery, which is a 510K FDA approval. And it was not specifically intended for left atrial appendage use, but that's actually the main use. So this has been brought up as a concern that, the intended use is actually not how the FDA approval was done. There is a study going on currently, the AMAZE study. It's looking at AFib pulmonary vein ablation versus ablation plus the lariat device. And it's not looking at stroke prevention. It's really looking at, is there a reduction in AFib recurrence with the combination, using the idea that you're eliminating foci from the appendage that may be causing AFib. Another big question is, it's a very local therapy for, what's a systemic problem when you look at stroke and coagulation. Also, you put the same table that Steve put up as well. So, this is the data we have from the late 90s. And again, the quality of the data is not great, but it does give us some information. They basically looked at TE, surgery, and autopsy studies that showed appendages, or a thrombus, and then tried to figure out where it was. And most of the time, if you had non-rheumatic AF, it was in the left atrial appendage, whereas in a rheumatic AF, a lot of times it could be in the main body of the left atrium as well. And this is where the 90% of the thrombus is in the left atrial appendage when you have a cardioembolic stroke. That still means there's 10% that's not there. So if you do a local therapy, there's 10% you're missing. The other concern is when you have a high CHAD score, you're just at a high risk of stroke. You could have other vascular disease, carotid disease. This is a local study using the Approach database, and Steve was actually involved in this study. And you can see on the left that your risk of stroke, TIA, or death all increase as your CHAD score increases, even if you don't have AFib. Although there's not an exact translation, an example would be like if you had a CHAD score of 6 without AFib, that is similar to about a CHAD score of 4 with AF in terms of stroke risk. And this obviously implies that, there's other non-cardiac areas where these strokes could be happening. And then, of course, there's studies like the COMPASS study with sort of lower dose of rivaroxaban that show that you can prevent cardiovascular events, including stroke. So there's thought that if you're on an anticoagulation, not only is it protecting you from left atrial appendage stroke, but maybe also from non-left atrial appendage sources such as carotid or other sort of vascular disease. What about the complications with the procedure? It is an invasive procedure, and this has also come into concern. So this is, again, that same table we saw earlier, and you can see that chronologically from the initial study to the later ones, the implant success rate increased from 90 to 95, and the overall complications decreased from almost 9% to 4.5%. But there's still 4.5 is not that small a number. And there's been recently, people have looked at the national sort of registry in the US looking at left atrial appendage with almost 50,000 patients. And there was a real concern that in women, the risk seems to be higher, about 6.3%, almost twofold increase, and it's mainly due to pericardial effusions. It's not quite clear why that is. Maybe there's some anatomic issues, frailty issues that all come into play, but it is a real finding that, and 6.3% complication risk is a pretty high risk. A complication that we experienced early on with our experience was actually a thrombus that was on the actual device. So this was called a device-related thrombus. And we actually published this experience at that time. So the 77-year-old lady, CHADS VASCAP3, recurrent GI bleeds. She had a Watchman implanted, and we did aspirin and Plavix as the therapy after. Unfortunately, like many of these patients, we had a recurrent GI bleed, which then necessitated interrupting and stopping the antiplatelets. She ended up in ICU. And then eventually, we had a lot of discussion and thought, well, maybe let's try warfarin instead. Maybe that would be a little bit different instead of putting her back on aspirin and Plavix. And unfortunately, like with a lot of warfarin issues, she was not therapeutic for quite a few weeks. When she had her 6-week TEE, it was clear that she had a thrombus, and that's the echo image on top there. So we added aspirin to the warfarin, and eventually she did get therapeutic. And then at the 6-month TE, there was actually no thrombus. So we stopped and she just continued on aspirin. Unfortunately, about 6 months later, she actually developed a dental abscess and subsequently got bacteremic and septic, ended up in ICU again. At this time, there was again evidence of embolic phenomenon. So the TE showed the device had a thrombus. And unfortunately, she passed away from sepsis and embolic events and ended up then getting an autopsy, which showed that the device, so if you look at panel A, it had not endothelialized properly. And this was actually the thrombus that was removed. So there's concern that maybe, this happened because early on in those first 6 weeks, she could not be anticoagulated properly. And maybe that's where, the thrombus developed. And maybe never completely endothelialized because of that initial critical period in the beginning. However, since then, this has actually been a much more recognized phenomenon. It's called DRT, or device-related thrombus. There's actually a registry that's looked at this and published recently. And it's found that probably in about 3 to 4% of left atrial appendage occlusion patients, these can be seen. And they looked at various devices. The majority was, of course, Watchman, but others were included in the registry as well. And the findings are impressive, just like the one we had, where you have the device, and then you can see a fairly big thrombus on the outside of it. And as we can imagine, this does increase your chance of having an ischemic event. So from 3 to 4% of those that have the DRT, then have about a 3 to 4% risk of that group of having an ischemic event. And this is, of course, just like any complication, but very horrible in the sense that the whole reason for putting the device in was to prevent an ischemic stroke. And now the device itself can be the cause of an ischemic stroke. This then compounds to the problem because then we have to prolong the anticoagulation. And remember, these are usually patients that cannot tolerate anticoagulation very well. So then this causes a problem in terms of putting them at risk for bleeding as we continue with the anticoagulation as well, even longer. The lucky thing is, like most of these procedures, any invasive procedure, it seems to be decreasing with time when you look at complications. So this is a chronological sort of list of the initial studies we talked about, or some of the newer kind of registry and other data that's been published. And you can see, especially for things like pericardial tamponade, it's decreased, but also in general for things like device embolization and procedure-related stroke, there's been a decrease in complications. Also, the next generation devices, such as we talked about the Watchman FLX, is made to have improvements on the previous device, and this probably helps as well. So the Pinnacle FLX study looked at 400 patients with the newer Watchman FLX, and you can see compared to the older generation, the complication rate was lower for a combination of stroke, embolization, and death. And again, Steve had mentioned this earlier. The concern is that, we want the patient when they show up for the procedure to not have a left atrial thrombus. Sometimes they do, just because that's the patient population we're dealing with. So ideally, we do try to anticoagulate or use antiplatelet agents for a few weeks prior to minimize that chance. This does, of course, mean they have to be anticoagulated pre-procedure for some of them. There's always heparinization that's done during the procedure because we are doing a transeptal going into the left atrium, and there's a chance that you could have a thrombus develop on the catheter and go to and leave and then cause an ischemic event. There's also post-implant. The recommended strategy is pretty aggressive with warfarin and aspirin for 45 days, and then do a TEE. And if it looks endothelialized and there's no thrombus and a leak is very small, you can have up to a 5 millimeter leak that's considered acceptable. Then aspirin plus clopidogrel until the 6-month mark, and then after 6 months, only aspirin. But in the real world, this is usually modified simply because they're always very high bleeding risk patients. Locally, we use a protocol that's similar to one of the studies that was done called the ASAP study. So we use aspirin and clopidogrel for 45 days, or these days we've also started using a DOAC, which has also been shown in another study to be a reasonable option. And at 45 days, we switch after a TE, and we also do a CT scan locally. We switch to aspirin. And many patients have stopped aspirin after 6 months, although it's recommended they, of course, continue indefinitely. And I would say almost 90% seem to stop it after about a year. But this obviously means that we need patients who can tolerate anticoagulation or antiplatelets at least for a short duration. And as Steve had already mentioned, there are guidelines out for left atrial appendage occlusion. Europe and CE mark was very early on with a lot of these devices. So in 2014, they actually had a consensus statement. AHA in 2019 gave it a class 2B, so that it could be considered in patients with AF who have contraindications to long-term anticoagulation. And the CCS in 2020 did go through this, and Steve had actually already mentioned this again, saying that it's maybe helpful in some patients, but the optimal candidates still remain unclear and really should be considered in patients who are at moderate to high risk for stroke, who have absolute contraindications to oral anticoagulants. And then I'll give it back to Steve, where he's going to talk about combining some of these procedures.
Thanks, Vikas. So yeah, we had a couple of recent cases where we combined with a Watchman implant with a catheter ablation, and I'll just talk about one of them. For those who don't do this all the time, atrial fibrillation ablation has become a very common and well-accepted procedure for patients with symptomatic atrial fibrillation. Typically in our center in most places involves primarily pulmonary vein antral isolation. So transeptal puncture, catheters into the left atrium, typically with a mapping system, or in some new cases with cryoballoon or radiofrequency ablation, and has reasonably good success rates. As you all know, the clinical folks on the call will all know, the demand for this procedure has continued to increase. And as such, we do have difficulty in meeting that demand sometimes in our EP lab. Next slide. So unlike for left atrial appendage occlusion, for AF ablation, the goals are really all about symptoms. We treat symptomatic patients whose atrial fibrillation is bothering them. And the goal is to improve their overall quality of life and their AF-related symptoms. And in many patients also to eliminate the need for antiarrhythmic drugs that are either causing them side effects or that worry them about their risk of proarrhythmia at some point in the future. Well, we know that it's effective for doing that. There's still some things that we're not sure about. So we don't have strong evidence, certainly not randomized evidence, that having an AF ablation reduces dramatically the risk for stroke or eliminates the need for stroke prevention therapy in patients who have elevated stroke risk to start with. There's some evidence that in patients with heart failure, it can improve heart outcomes like mortality. But in the majority of the patients, we don't have evidence suggesting that it does that. We also don't have great evidence about overall hospitalizations or survival in the overall cohort. So the bottom line here is that it's all about symptoms. Next slide. In terms of patients who are not good candidates for ablation, certainly patients who are completely asymptomatic from their atrial fibrillation, and then people who have some markers where it is highly unlikely that anything we do will keep them in normal rhythm. So very long-standing atrial fibrillation. The exact threshold is not known, but certainly the longer you are, the worse it is. By the same token, very extreme left atrial enlargement. Again, no hard cutoffs. It's just something that we put together with the other factors. It is possible to do an ablation in somebody with a mechanical mitral valve, but there's some significant challenges related to that. And of course, patients do need to be able to be anticoagulated for the procedure and thereafter. Next slide. Both from our local assessment and from what we know from clinical trials and registry data or from other places, we know that this procedure is very likely to be acutely successful, meaning at the end of the procedure, we can isolate the veins as we intended to do. I always tell my patients that doesn't mean that there's a 90% chance they're not going to have any more AFib. It's something more like 50 to 60% with one procedure and maybe up to 80% with multiple procedures. And we always tell people this is not a cure for atrial fibrillation in most cases, and that we have seen people with very late recurrences, but it can be very good at improving symptoms. Next slide. Like for any invasive procedure, there are complications expected, and here our risk is around 4%, and we track that carefully, including the outcomes that you can see there. The ones in the lower part have become very, very uncommon with our current methods. Next slide. So what about combining the two procedures? So there are some practical rationales for why you might want to do that. So there are common pre-procedure tests that are used. So transesophageal echocardiogram and left atrial imaging, either with MRI or CT, are typically used for both ablation and for the left atrial appendage occlusions. And a lot of the equipment and initial steps of the procedure are quite similar. So general anesthesia, transesophageal echocardiogram commonly used, and transeptal access to the left atrium. And so we can imagine that there may be some cost savings in terms of if patients want to have both procedures, to not having them have to be admitted twice and go through all these steps twice. And because of the commonalities, adding the Watchman at the end of the pulmonary vein isolation really might be expected to add less than an hour to the overall procedure time, I think, which is acceptable. And then, yeah, with the Watchman in patients who do desire to come off of anticoagulation, there may be some rationale that they could be able to more comfortable in doing that. But it's not all clear. So there are some reasons why it might be difficult or not a good idea to do it in some cases. So you need to have obviously the right team in place, which we are lucky that we have here. We started out with electrophysiologists doing Watchman devices or left atrial appendage occlusion devices, and that's not the case everywhere. And the lab environment and the team needs to be, capable and trained to do both procedures. If an operator is using a cryoballoon ablation, then both procedures require a little bit of contrast. I think this is, for most patients, not a major concern, but it is worth thinking about. A small technical issue is that the ideal transeptal location for the appendage occlusion is not actually the same as for an ablation, although again, I think this is manageable as well. And then there is a theoretical concern that if you do ablation, you're ablating often on the ridge between the left upper pulmonary vein and the appendage, and theoretically that could lead to tissue edema that might affect the sizing of the left atrial appendage. And in the worst case is that as that edema resolves, you've put in the wrong size device, and there's still some leak around that. Next slide. The bigger issue, I think, is that as I'm trying to depict here, this is by no means quantitatively accurate, but we know that most of our ablation patients are highly symptomatic, relatively younger patients, and many of them have reasonably low stroke risk and tolerate anticoagulant pretty well. Whereas those referred for, at least in our experience here, for appendage occlusion tend to be older, frail, often asymptomatic from their atrial fibrillation. And so there's not a huge number of patients where that indication overlaps. Next slide. There's a little bit of data, and I'm not going to go through this in great detail, about combining the procedures. All of it is observational. This is a meta-analysis that came out last year combining all of those studies. And there were 16 studies included overall, something like a bit more than 1,000 patients overall. And they looked at things like procedural success and safety. And this is the summary here, that the ablation success seemed to be comparable to other cohorts, that they were able to seal the appendage appropriately, and that the complication rate didn't seem to be increased compared with the procedures done in isolation. So reasonable, I guess, to consider in the appropriately selected patients based on this limited data. And as early as 2014, the European group suggested that this could be done in appropriately selected patients who need both procedures. Not a strong recommendation. So just to end off, I'm going to go through the case that we did very briefly here in Calgary, just in November. This was a 72-year-old man referred from a cardiologist in Edmonton, whose actually main reason for referral was because of symptomatic AF and requiring a rhythm control approach despite amiodarone. He actually had reasonably low stroke risk, but had a spontaneous, so actually his stroke risk, his transvascular would have been 2 because of his prior bleeding stroke, mild left atrial enlargement. And he actually saw Vikas in consultation and reviewed all the options, and he was consented to a combined procedure. And on the pre-procedure imaging, really did have quite a favorable anatomy for the appendage occlusion as well. So this is some nice images that the company that supports this device provides in the prep. They take the CT and they really do some sort of nice images that help us to plan the size and the approach to the device. And this person had quite a wide and large appendage, and with no real particular difficulties, except that it was relatively shallow. So the original or old-fashioned Watchman device wouldn't have been good, but the new version of the device would fit quite well in there. So next slide. So there's a couple of modifications to our typical pulmonary vein isolation protocol that we would use. Of course, we have general anesthesia, and we have one anesthesiologist who works with us who has substantial Watchman experience from their training. So he tends to come for these procedures. On this day, we had one like physiologist, myself, as well as Anna Bizios from interventional cardiology. We started with the pulmonary vein isolation, and we used 2 separate transeptal punctures, which is a slight modification to my normal protocol for pulmonary vein isolation, just to make sure that we had one that was in the right spot for the Watchman. Next slide. So it's just showing that in this case, the pulmonary vein isolation was successful and thankfully fairly straightforward. And we were able to proceed to the Watchman reasonably promptly. We did take one of the sheaths out of the left atrium after that, just to keep things out of the way. And then had a fairly, I won't go through all the details here, but did have a fairly straightforward implant of the device. We did have to redeploy it once, which with the newer device is much less of a rigmarole as the old one used to be. And in the end, is quite successful. And he had a follow-up transesophageal echocardiogram just a little while ago, showing that the device is in a good spot with no leak. So it's so far a good result. I haven't heard whether his ablation is successful yet, but
yeah, I haven't seen him in follow-up yet, Steve, but
yeah,
at least from the Netcare notes, it looks like things are pretty good. Just to recap, I think what we've gone through, it is a very select population, that we usually put the device in. They're patients with non-valvular AF with a very high risk for stroke and bleeding. Typically, they've had recurrent bleedings, but it is important that they can take antiplatelets or anticoagulation at least for a few weeks, because we do need to do that peri-procedure and with appropriate sort of suitable patient and anatomy. When you look at the overall comparison, if you estimate what would the stroke risk have been if they were on a single antiplatelet agent, looking at some of the studies, it's about a 60% stroke reduction. But keep in mind, there can be a 4 to 6% risk of complication with the procedure. And I think the shared decision-making is very important here, because a lot of the patients we see, if you go back through their history, years ago, they had AFib, they were told that they're at high risk for stroke, they were placed on an anticoagulant, they have a bleed. Sometimes they tried a different anticoagulant or they don't want to go back on it. And, because of the initial thoughts that they were, of course, told that they were high risk for stroke, they're very uncomfortable just saying, hey, I don't need anything now, they know that I have to bleed. So this is an option that a lot of them seek out, and, and making sure they understand the risk and benefits is very important. And in some cases, like Steve had pointed out, it might be that combining the procedures may be appropriate. And in fact, that is one of the areas where there is some studies going on. There's 2 studies looking at AF ablation and left atrial appendage occlusion at the same time. One's the option study and the other's the AMAZE study that I mentioned earlier with the Lariat. There's also studies looking at left atrial appendage occlusion still. So the ASAP2 studies randomizing to left atrial appendage occlusion versus standard or no treatment. Typically, that's either aspirin or nothing. So hopefully, as time goes by, we will gather more evidence as well. And I think, as we pointed out, this does require the work of lots of different groups, including EP, two of our interventional colleagues are now getting involved with these procedures as well, with for Anna and Ayaz working with us now. Then we have a dedicated radiologist who looks at our CT, and Jeff's our anesthetist who's often involved. Then we obviously have help from Echo Group, Jill and Greg locally, as well as one of the Echo docs in Edmonton, because a lot of our patients come from Edmonton now as well, because we're the single site in Alberta. And obviously we get a lot of help from our, operational and as well as our EP and cath lab teams. And there is some industry support that's required for, helping with device selection and with the TrueView kind of images that Steve showed. So it is a group and collaborative effort that I think we're lucky that we're in a place like this where we can have these kind of connections happen. Yeah, thank you all for coming and listening to us, and we can take any questions if you guys have.
Thank you, guys. That was great. A couple of questions and comments. So the AMAZE trial was already presented and basically showed that it was, so the trial basically what it was doing, it was randomizing people to the lariat plus pulmonary vein isolation versus just pulmonary vein isolation, trying to see if the combination of these would reduce outcomes in atrial fibrillation. It was non-inferior and did not show really any advantage of the lariat. As a matter of fact, showed that safety with the lariat was not that good, and there's still significant residual flow there. So I think that question probably was the wrong question, but but that's a story for another day. Another comment is that I saw there that you indicated, one of you indicated that AF ablation was contraindicated in asymptomatic patients. So I'm not so sure about that, because as we know, a lot of our patients with persistent AF are primarily asymptomatic. And, based on the recent data from the AFNet4 in the asymptomatic population also, it seems that, not necessarily ablation, but rhythm control is definitely superior to rate control. So I think it's important that, this is a moving target, of course, but in the future, we will be looking into this more seriously, probably particularly the population that has LV dysfunction. Last but not least, so you did show the LAAO trial there. So why is this different from what we do with the Watchman? So would we get better outcomes with maintaining anticoagulation in spite of getting Watchman?
So don't know. We just don't know. It's different patient populations in LAAOs compared with our typical Watchman population. So yeah, I think that's a trial that could be done if people wanted to do it, but I don't think and I think even Rich Whitlock is very clear in saying he doesn't expect that the results of LAAOS 3, can be extrapolated easily to percutaneous therapy.
Yeah, but I mean, the issue that we've had with percutaneous therapy is that we haven't shown really that there's a reduction in ischemic stroke.
I think that's a good comment, Carlos.
Which is really the fundamental reason why we want to anticoagulate people.
Yeah, so I think there's two things there. One is, on the studies that we're looking at where we're saying it didn't reduce stroke, we're comparing it to anticoagulation, right? So I think that's a little bit different. But your point is, it's a good question. So I know in Quebec, they get a lot of neurology referrals for patients with a high CHAD score who are anticoagulated and still had a stroke, and they thought it was cardioembolic. And in those patients, they've actually done what you're suggesting, where the Watchman or whatever, appendage occlusion you use is an adjunct to anticoagulation. They still stay anticoagulated after, because those are a tough population where, if it's warfarin, at least you can say, oh, maybe your INR was not therapeutic. We can look at the INR. But if they're on a DOAC and they say they took all their doses and they still have what looks like a cardioembolic stroke, what do you do, right? And so I know in some of those patients, they've been doing that strategy. And I think you're right. If we did that strategy, you probably would see possibly a reduction in ischemic stroke. But it's a very different population, I guess, right? I mean, I know in the US and, some of the European countries, the threshold is lower. And certainly, if you take healthier patients and do the procedure, you probably will have better outcomes. And maybe, if they can stay anticoagulated, you might see a reduction in stroke as well, I guess, in those populations.
Yeah, and I guess the challenge I'm having is with the population that we want to do the combined procedure, because we're primarily doing these, Watchmans and people that have a lot of contraindications for anticoagulation, which seem to be in contradiction with the patients that we do atrial fibrillation. So how do we find that perfect candidate?
Yeah, I think my thought about Watchman is, and it really is a distinct, I think, compared with any therapeutic procedure, this is a procedure that's purely prophylactic. It doesn't make anyone feel better. And it's fairly invasive and does have reasonably high serious complication rates. So I think we do have to have a very high bar for doing that to people. We know that especially in contemporary cohorts, the stroke risk if people are appropriately anticoagulated is very, very low. And so telling them that they need to as well have a procedure, unless there's a really good reason, I think we're not there. We're probably not going to get there in Canada. It's my thought, and that's probably for the best.
No, I agree, because the thing, when you look at the literature of the combined procedures, and I'm probably the most aggressive of the three of us here, but the fact is that when you look at the literature, it's more a convenience thing than really an evidence-based issue. It's like, the 50-year-old guy, I don't want to take anticoagulation, plug my left atrial appendage when you finish your ablation, which I don't think it's really appropriate in most settings anyways. So, still lots to learn in this area, and I think there's still lots to do. But, we do have a great team, and we do collaborate with the stroke neurologists here. And obviously, we're happy to do all the cases that you guys send us if they have an indication. So I don't know if there's any other questions. I haven't looked at the chat. Let me see. Nope. Any other comments from you guys?
No, I mean, thanks for everyone for
yeah.
listening. And it is a tough population. I mean, it's a very select group that we're taking, and unless we have better evidence, I don't think it'll dramatically change.
I got a quick question. That Jorgo here. There's been some favorable evidence recently in favor of surgical left atrial appendage removal, as you know, at the time of other cardiac surgery. Is there any patient you might consider that you just send them for a surgical removal of their left atrial appendage instead of doing this?
Yeah, we haven't done that here, Jorgo. I know some of the US centers have done it using sort of minimal, I guess maybe thoracoscopic means. And I think, we could talk to our surgeons, but I think most of us would think that doing a standalone, especially if it requires a sternotomy, that would be a pretty big procedure for, left atrial appendage remover. But there's some centers where they said if you absolutely can't be anticoagulated at all, even for the hour we're in the left atrial appendage, maybe they would consider sending for some sort of a thoracoscopic procedure. But I don't know how many anybody's actually done, because that would be the only patient where you think that it'd be a good candidate, because we simply can't anticoagulate them with the heparin during the procedure or do the 4 weeks after. But I don't know if maybe Steve or Carlos knows more about that.
I don't know more about it, but I think that it is conceivable if it could be done relatively minimally invasively, and if they can replace or repair the mitral valve minimally invasively, I assume they can tie off the appendage as well. So there are patients where you can't do a transeptal, for instance, or as Vikas has said, other ones. So I don't think it's impossible to consider.
No, that's been done in some centers in Europe, particularly, there's still 1% maybe failure of trying to deploy the device. And, these people mostly have atrial fibrillation. So what they've done is they've done minimally invasive, AtriCure plus clipping the appendage, the left atrial appendage. And there's a few case reports on that. But that would be a rarity, but, still does happen. Okay, well, if there's no other comments or questions, thank you guys. That was a great presentation, and have a great day.
Thanks all. Bye-bye.